Well, hello everyone. Welcome to the class today. Thank you all for coming. Today we've got the topic here is going to be EKG for the EMT basic. EKGs are normally thought of as being something for paramedics and the higher level care to provide. However, with the way things are going now in medicine, there's much more of a push for the first medical people on scene to be the ones applying the EKG. So that's what our overview is going to be about today. So again, thank you all for coming. Recently, I got the pleasure to attend a Bob Page conference, and as part of that conference, they talked about the number one advantage and the number one push right now is going to having the first medical contact to a chest pain patient or a possible STEMI patient being the one to apply that EKG. Now, granted, it may not be the first medical contact, it may not be the one who can actually interpret it, but at least we can get it and go and have it acquired first off. And then that way, the way modern technology is moving, we can go ahead and have that either transmitted via the radio system or cell phones, whatever, to the hospital. And your emails on the way can go ahead and know, hey, this is going to be something that's a critical patient. We need to get this patient load and go. Let's move. So that's going to be our topic for today. Excuse me. A couple of our objectives here we're going to work on is, as we see here, first off, we're going to start off just basic again. I know it's probably been a while since basic class, so we're going to go through again, just review that anatomy and physiology of the heart. Just the basic overview, what's going on inside there, what should be going on, how is a normal person going to be set up, and then just simply follow just the pathways of the heart and the way the blood follows, and then each of the chambers and what each part has to do. Secondly, we're going to look at the indications for running a 12 lead. Obviously, not every patient needs one. But there are some patients that will need it more than others, and even some patients you may not think of. So that's going to be what our first goal is going to be on here. We're going to look at, thoroughly there, how to prep the sites and to place an EKG on a patient. The way you've probably seen it done before, different medics come up, pull it out, just pull the stickers out, the electrodes, just slap them on the patient. There can be a lot more prep that can go into that and actually give you a better quality reading than just a trashy, very staticky reading that you see a lot of times. So we're going to look at that as well. What information is going to be needed for that 12 lead? We need to have, what will be what you need. Obviously, most patients, you don't have to go through and put in their entire name, their birthday, everything else. However, their age and their gender are two things that are very important. A lot of our monitors are actually programmed to where whenever you get a 12 lead, all you have to do is put it in. As soon as you hit that 12 lead button, it'll ask for their age and then their gender, and then that's it. And then it automatically starts acquiring the 12 leads. So that's one thing we're going to look at. And then how to translate or transmit that information to the hospital or to the responding EMS crew. Those are the big things going on right now. Is what can we do to improve our times from the, you hear all the time, the door to balloon, and really the scene to balloon time. How fast we try to get that artery back open for the patient, and ultimately improve their outcome. So that's going to be what we're looking at today. So again, we're going to start off with some anatomy and physiology review. As you see here, the heart has 4 chambers, as we've all talked about before. In fact, if I can pull up to the side here, I don't have an extra marker yet. There's one of my former instructors in EMT Basic always took us the very first thing, and he would draw out the heart as a circle. So I'm going to do that here today. That has always stuck with me. And this marker's not working. Here we go. So, obviously the heart does not look like you see all the time. It's not just a real pretty heart like you see Valentine's Day those times. But, to keep it simple, draw the heart into four chambers of a circle, or a square, whatever design works for you best. And then you'll just label it. You'll have the right atria, because remember, this is a patient, you're looking at it backwards. Left atria, right ventricle, and then left ventricle. Now the way the heart comes into the body, first off, you have the vena cava. You have the inferior coming from the bottom, and the superior coming from the top. That's where your blood comes into the right atrium. And from the right atrium, you'll go through a one-way valve. That valve is called the, tricuspid valve. It's the first one that comes in through. The tricuspid valve has 3 flaps. That's how it gets its name. Very creative there. Did a good job with that one. They made it paramedic proof, if you want to call it. From the right ventricle, it is then pumped out into the pulmonic system. Now this is the pulmonary vein. It's the only vein in the body that circulates deoxygenated blood. Or correction, it's the only, let me back a minute, it's an artery, and it's the only artery in the body that pumps deoxygenated blood. From there it goes out to the lungs, where gas exchange occurs. We'll talk about that more here in a few minutes. Once that gas exchange occurs, then you come back into the left atria from the pulmonary veins. Those are the only veins in the body that carry oxygenated blood. So from the left atria, then you go through another one-way valve called the mitral or the bicuspid valve. Very similar to the tricuspid, except it only has two flaps. And Dr. Mitchell, the one who discovered it, wanted his name on something, so he got his name on a valve. From there, it pumps into the largest part of the heart, which is the left ventricle. That left ventricle is the one you hear about all the time because it is the one that is like the powerhouse of the heart. It has the responsibility of pumping blood through the rest of the body. And so it's the biggest, the strongest muscle of all of them. From that left ventricle, though, that strong one, it then pumps out, back out, the aortic valve. It's a very big valve. A lot of people you'll hear that have valve replacement surgeries. It'll be that aortic valve. It's a very common one just because it's beat up so much. My chief of my fire department actually had his replaced 2 years ago. He got a big valve. So he looks at making a whole new way nowadays. But from that aortic valve, it then pumps out in through the pumps out the aorta, then out into the systemic system. And if you want to dig into a little bit more, actually see that corner picture here. Out through that aorta, it's right there at the very beginning of the aorta is where you get your cardiac circulation from. There's a few branches off of that then circulate and supply the oxygen to the heart. So again, if you look at this picture here, it really draws it very well. Despite my wonderful circular drawing, which I do not have art skills, you see it again, comes into the right atrium, where it then goes to the tricuspid valve, and then it's the right ventricle pulmonary circulation system, circulates the blood, circulates the gases, and the gases come back into the pulmonary veins, into the left atrium, through the bicuspid or mitral valve, into the left ventricle then out through the aortic valve, aorta out to the body. So there's where we get our big circulation through the heart system at. Just review that a little bit more. All we just talked about here. Blood comes from the vena cava, right atrium, into the heart, and this whole system there. We're going to hit on here real quick is the bottom of this right here, where it talks about in the lungs, the gas exchange occurs. We're not going to hit on it much because it doesn't really matter at this level. The big key for us is we're just wanting to make sure that oxygen is actually cycling out and converting the carbon dioxide for oxygen and kind of just cycling back and forth that cycle that actually provides ventilation for the patient. As you see here, here's your deoxygenated blood coming from the artery side, and then you get your gas exchange here where your oxygen comes into the blood, and your carbon dioxide goes out back to the alveoli, where it then goes back out to the lungs, and you then get your ventilation again there. Oxygenated blood comes out through the venule into the pulmonary veins, then back into the heart. This picture here I think is pretty, it's very helpful just because it does give a good look at it, and a little blurry for some reason right now, but it gives a good look at how the whole system works there. If anyone wants these slides here, let me know, and I can shoot them to you. In this picture here, your dark red blood is your oxygenated blood, and the light tan color is your deoxygenated blood. And it just shows how it circulates out through the lungs and then back into the body. Other side of that cycle we just talked about, oxygenated blood returns into the left atrium. It's pumped through the mitral valve into the left ventricle. The left ventricle pumps it out to the rest of the body. So in our hearts, we have our cardiac conduction system. That is what gives our heart the rate, the rhythm, the wherewithal to keep on pumping. There's really three primary methods that keep up the beat, keep it pumping. The first one's the primary one. It's our sinoatrial node. You will hear it referred to most times as the SA node. SA node is the one you want to be working, and because that's what your normal system is. Its normal rhythm or normal rate is about 60 to 100 beats a minute, and that's where you want to be living at. That's that normal, comfortable range. That's where all our body's in its normal, happy homeostasis state. Next one, if for some reason your SA node fails, you can then back out to your to the atrioventricular node, and your AV node is right there in the middle. It's what, as it says there, it's the atria and the ventricular. I got our next picture here, actually shows you where they're all placed at. Its rate, its normal rate, that if it's working properly, is going to be at 40 to 60 beats a minute. And that's just the first level of backup to the SA node. And your body's, it's still okay, you're still living, you're still working okay, but your body's starting to not be happy. It's starting to get a little bit agitated. Now, whenever you get to your last resort, which is your Purkinje fibers, now you're really in trouble. This is when you get into a ventricular rhythm. Your heart rate's going to be somewhere between 50 and 40 beats a minute. Some textbooks will even say 20 to 30. So either way, you're going to be down really low, really slow heart rate. And this is your last resort. It's basically the cells themselves firing off. Nothing else giving them the wherewithal to go. They're just going on their own now. Our cardiac inertial system, as you can see here, a little better picture of it all. SA nodes, it's right up here at the top. And it first off gives your cardiac action potential to the atria. That's what you want to fire first. When your atria fire, then that cycle, as it works through, makes it down to the AV node. Once that charge gets to the AV node, the AV node says, okay, a little bit of delay, now I send it off to the ventricles. And the ventricles fire shortly after the atrium fire. That way you get the pumping, you're not all pumping at the same time. It gives just enough time for the blood to move and then be able to circulate out through the body. As you can see here, the bottoms are Purkinje fibers. Those are those last resorts that are down in the ventricles themselves. If you went down at that point there, you're not happy. As you can see here, the arrows also show you how the action potential follows, where it starts out that SA node, comes through, and then all the way down to the bottom of the heart. So it actually shoots from top to bottom. That's the normal happy state. Definition of your heart rates, you probably heard before talking about like tachycardia or bradycardia, and really simple definition for those. If it's less than 60, it's a bradycardia rhythm or bradycardic rhythm, and if it's over 100, it's a tachycardic rhythm. That way it's just a very easy to keep in mind, easy to remember, and you can then have other interventions based off of what their heart rate is at from those boundaries there. So we talked about this class. Obviously, the goal of this class is EKG reading. I just want to start off with a basic EMT. We'll come back into that, the action potential and the cardiac cycle here in a minute. But either way, we're going to break it down here and talk about our EKGs. Who all has not seen an EKG before? I'm talking to an empty room. It's really awkward. Anyways, so you may have seen one before, however, you may not know what it all means. And so that's what we're going to go over here. As you look at your box here, this picture here represents a normal 12 lead. You'll have your 12 different views, and then at the bottom it has just a regular running strip. That is normally it's going to be lead 2. We'll get into that in a minute, don't worry about it. But just a continuous running strip of one view of the heart. Zoom into it a little bit here. You have each strip, you'll be broken down into smaller boxes, which are then broken down to even smaller boxes. Each of the very small boxes is 1 millimeter by 1 millimeter. When you look at it, 1 millimeter horizontally is equal to 0.04 seconds. You use that to determine how fast your heart rate is or slow, and then how long each portion of the heart takes to beat. And vertically, you'll have 1 millimeter. That's what you can use to determine if there's any part of the heart is upset, if anything is oxygen deprived, or what we call ischemic, which is basically your heart attack. If you've heard, MI stands for myocardial infarction. And infarction can be determined by how much elevation is in a certain area. Quick review on that. Anyone got any questions? No? I want to make sure I'm not moving too fast for anyone. Actually, look at your EKG and your regular 12 lead, and I have a couple here we'll pass around. You can look at them. Each section of the heart, each section of that 12 lead gives you a different view. Easy way to remember it is I see all leads, ISAL. Your first section is right over here starting at lead 2. skip the top lead, and you have your inferior section. It takes a little bit getting used to looking at it this way, but your first one's lead 2, 3, and AVF are your inferior leads. And again, it's just anatomy physiology. It's cool to know, you're not required to know it, but it's kind of just helpful information to know whenever you're looking at a 12-lead EKG. So, like I said, your first section is your inferior side of your heart. It's typically thought of your right side. From there, your C septal leads, S-E-E-C, not C letter. Septal leads are the inside part of your heart, the septal portion there in the middle, anterior, again talking about the back side, and that would be V3 and V4, and then 5 and 6, and then jump back to the other side. Lead 1 and AVL are your lateral portion. And so that kind of gives you an idea of wherever you see your ischemia at, that can be where you use that related to this chart, and then you can tell where your heart attack's occurring at. And for us, it doesn't mean that big of a deal, but it can mean the difference of like whether you give, for example, nitroglycerin or not. We'll talk about that again in here in a little bit, but real quick, if you see an inferior heart attack, you want to try to stay away from giving nitro, just because it can make the patient worse off. Anyways, so just a quick review on that. We can now pass around some 12 leads here in a minute so you can actually see it. And any questions on that? No? Okay. So here's probably the view you're used to seeing on the side of an ambulance. However, on the side of an ambulance, medical building, whatever, it's normally much, much wider, totally inaccurate, but they still put it up there anyway. So what you have, each phase, meaning each wave represents a different portion of the cardiac cycle. In that cardiac cycle, you'll start off with, that should go from left to right. And again, once you overlay this with your 12 lead, you can see how much time each portion takes. And for example, your normal portion from this PR interval I mentioned here should be less than 0.2 seconds, which is one of the darker pink lines, or red lines depending on your machine. And in length, don't worry about knowing that. It's just, we'll kind of pull the two items together here in a minute, so that way you can understand better what we're talking about. Your P wave though, first off, the first little wave normally should be an upward deflection. That represents your atrial, the atrium on top of your heart. They should be depolarizing or squeezing. That's what is indicated by that first wave, is their contraction. However, keeping it in terms of the electrical system, we call it depolarizing. The second section here, you should have a little bit of a wave. This PR segment is just the time it takes really for the that signal or that electrical charge to go through the AV junction we just talked about, the AV node. That's that little bit of delay there. Then next, you go to your QRS. This is the big wave in the middle. From this here, this is the main portion of whenever you feel your pulse. This is what you're feeling happen. The main portion of this being your R wave. That is when your ventricles squeeze and causes your that's when the R wave is whenever the action potential is given to your ventricles and your ventricles contract and squeeze, depolarize in other words. Also during this portion here of the QRS, you also have your atrium repolarizing and getting ready for the next beat. However, because it's hidden underneath this, the big complex here, the ventricles contracting, you can't see it. It's just interesting to know it's there. We just can't see it though because of the QRS, QRS segment there, complex. The last one here, the last wave you should see, is your T wave. And your T wave is just your ventricles repolarizing and getting ready to contract again. Basically, they're getting recharged, ready to fire off again whenever they get their signal again. Next time around, however fast the heart's beating will determine how fast they actually get the charge delivered back to them. Occasionally, you will see what's called a U wave. And I say occasionally, meaning once in every 500,000 patients. They are very rare. However, if you see another funky wave at the end, I'm sure you'll probably forget this after today. I forget all the time because you never see them. But if you see an extra wave there, don't be too concerned about it because there is certain conditions that can lead to that U wave being there. Comes up here. this cycle here, I pulled this picture off another slide we had, and it just kind of relays those two ideas together. You see your or the way the action potential goes through the heart. I'm sorry. Starting off at your SA node, you can see how that relates to your the first portion of number 1 of your atrium getting ready to fire. Number 2, as they come through those green lines there, green brownish looking lines, that is your atrium getting their charge, depolarizing, contracting, and it is indicated by, as you see, that first wave, that P wave. Second portion here is that pause right after that P wave. You can see here the yellow AV node. That is that delay. It's the little bit delay that the reason it's there is because it gives the blood enough time to get through the valves into the next chamber of the heart before the heart contracts. Certain portions of your or certain rhythms, if your heart is beating too fast, it doesn't give your blood time to move, and so that's for the reason why with certain, for example, a very fast heart rate, you'll be feeling dizzy or you maybe a lower blood pressure if it's that bad. Just because there's not enough time to actually move the blood. Next here, you see the, it comes into the bundle of his, or the his bundle. It is that next section to where it gets ready to start up for the QRS complex. That is when your ventricles are ready to contract, and they are starting to contract, and you're really giving that beat. It's kind of hard to see the lines in this slide, but you have really related here at step 4A is your first part of your beats here. The second part, on your down wave, is the bottom part of the bundle of his and your Purkinje fibers contracting. That signal's gotten all the way through, gotten to it, it's made it. It's at almost the end of its action potential, or the cardiac cycle there. And finally here at the end, you see, relating here to pictures 5 and 6, are, okay, it's done, the contraction's done, the heart's back to a, if you want to call it a resting phase. Nothing else is going on at this point, and then once it's ready, once that phase is completely out, the energy is depleted, and then you see step 6 where you get that T wave, and then they get recharged, ready to go back in, ready for their next beat. Any questions about that? All right. Next one here we're talking about is prepping for our EKG patient, or EKG placement, I'm sorry. And like I mentioned earlier, you see so many paramedics who come up, and it's not just paramedics either, so let me take a step back from that. Even the respiratory therapist or whoever does them in the hospital will do the same thing. A lot of them just pull up their cart, slap stickers on, hit print, they're done. However, believe it or not, that's not exactly the best way to do it. You should take the time to truly prep the skin, and because taking that few extra seconds to truly prep the skin, you will in turn get a much better, cleaner, and more effective reading. Now, I've heard said before, again from the Bob Page conference, and Bob Page is just he's developed a company, if you want to call it that. That's 12-lead medics, or multi-lead medics, and he's been doing 12-lead stuff all across the country. He's just extremely smart guy, and he knows his stuff and does it everywhere. But he was talking last week at this conference about how in the old days you had your rhythms or your monitors would give great readings because they were so filtered. You didn't get any of that artifact that you see nowadays. Because at that point, they weren't so concerned about finding the extra elevation to find that heart attack, because they were more concerned about getting a clean reading because they didn't know what they were looking for with that elevation. Now that we know what we're looking for with that elevation, it's helpful if our monitor can actually pick it up. And so that way we can say, okay, we know what we're doing here. And we can see that with a highly filtered monitor or a tracing machine, you can't see that. So that way today they're not quite as filtered, but you can see more with them because of that. So the first step is be very simple. Just take a towel, wipe off the skin. If it's wet, dirty, say you've been working outside, whatever, just wipe that skin down. Try to get those dead skin cells off the top. That can be, believe it or not, make your reading 10 times better. Just getting that extra layer of skin cells off there so you can truly get your stickers down to the skin. And when you pull them out here, we can pass them around. Inside that electrode, the sticker that goes on the skin, you have a sticker around the outside, and then the inside of it has a little gel. If you remember back in the old days when they had the paddles, the jelly they put on the paddles before they gave the shock, it's kind of the same gel. Except this one, we don't squirt it out of the bottle. It's already on those stickers ready to go. All we have to do is pull it out and stick it. So like I said, the first step here, clean that skin using a dry cloth, something to just clean it out, get the dirt and grime out of the way. If someone's put on lotions, for example, you want to try to get those off. Get that skin as clean as possible, so that way you can get the best sticking and the best reading from that. Inside the body, the muscles are a great conductor of electricity, and muscles in the veins get that electricity from the heart down to the limbs where you're going to be sticking the wires and sticking the electrodes. Through that whole system, the skin is the worst part. It's the poorest conductor out of everything. So we want to try to make that, I won't say as thin as possible, but give it the best chances possible to be able to read through the skin and pick up that reading there. So use a towel or dry cloth, and you really wipe it just kind of a circular motion, try to get the dirt away from the area instead of getting it, instead of just wiping it down, because so many times with just wiping it down, you can pick it up and bring it right back on top and wipe it over the same spot again. So if you use that circular motion, try to just brush it truly away from the area. It works great. Either way, anything's going to help. You may get laughed at by a few medics who come up and see you wiping the skin before you put on electrodes. Just tell them they need to go back to school and learn how to do the job. Don't really do that. I'm just say, okay, thank you. Anyways, then like I said here, try to remove just any of the extra foreign objects that are there in the way. That can really affect your reading. Extra point here is, I don't know if I put it on the slide or not, do not use an alcohol wipe. You may think that might help. Hey, they use it for IVs and everything else. However, at this point, we're not worried about being sterile or aseptic. We're more worried about getting the extra dirt out of the way. And the alcohol can actually affect it in a negative way for your stickers and your tracings there, trying to get a good reading off of the electrode. Also, if you have a patient who is very hairy, hopefully they don't have as much hair maybe on the inside of their arms, you can find a good spot to stick it. But it may actually be necessary to shave the skin and shave that hair out of the way so you can get a good sticking, a good placement on your electrode. Maybe not as much on your limb leads, but on the chest it might be necessary and very helpful. And as we mentioned here, correct placement of those electrodes is key. That's what we're wanting to go off of. And you've already mentioned most of this here. But another one is you get on, for example, on your arm especially, you want to try to avoid that area around the wrist where the skin is, or the bones and tendons are right there at the skin. Reason being, one, it's not as, you don't have the muscular area underneath it for the good conduction, and also, with that, any movement they make will be amplified because the bones being right there, it can just make your reading harder to get. So you want to try to go for the more muscular area, come up a little further on the arm if you need to. In some ways, part of the reasons why the hospitals will put them on the actual torso of the body. But either way, you can actually get a better reading, a more accurate reading, I should say, if you go out truly on the limbs instead of going on the top of the chest and the stomach area. So work for really the middle of the forearm is a good place. Some of your old ladies, with very thin skin and very little meat on their bones, it can be hard to find a good spot. So just give it the best you got. And after you do a few of them, you'll kind of see and pick up and learn where you need to be going for. Like I mentioned earlier, avoid using alcohol. Limb leads are your first ones here you'll put on. You'll hear it called a 3-lead or 4-lead, depending on what time area you're from or wherever you went to school at. You call it both ways. Hopefully they'll know what you're talking about either way. Technically it is a 3-lead, but either way, you have 4 wires, and a wire is an electrode, not a lead. A lead is technically a view. So as you go through, your first 4 wires will be your limb leads. Self-descriptive should be. They go on the limbs. Imagine that. So they are LL for left leg, RL it's backwards. LL for left leg, LA for left arm, RA for right arm, RL for right leg. They're also color-coded. If you want to try to remember, red goes on the left leg, black goes on the left arm, white goes on the right arm, and green goes on the left or right leg. You can do that. A lot of times it's easier. They make them paramedic proof. They're written on it where they go. So just look at it. Oh, LL. I bet that goes to the left leg. Simple to remember there. Try to place them as far distal as you can. However, like I just mentioned, middle of the forearm is a great place for them. That way you get the good meaty surface, and it's a good place. Normally there's plenty of area to stick it to, and so you pick out a good spot there. There's just where your locations are at there at the end. Your chest leads are also called your precordial leads, but they're, you can hear them called either way. Your chest leads, your 6 lead wires, whatever else, you hear them called. Your chest leads is a good view for them, or good word for them, and they are limerick V1 through V6. And as you see here in the picture, we'll get into it hands-on in a few minutes here. But from these extra 6 wires is what makes up your 12 lead. From just the first 3, where you get 6 views still with the first 3 wires, but with these here, you can go ahead and get the rest of your views as well. So your first one, V1, is the first one you'll stick on, and you'll find the 4th intercostal space down the chest, and stick it right there on the right side of the sternum, of their sternum. Not if you're looking at them; it's the right side of the patient's sternum. You don't mix up all the time in your head if you're thinking of it wrong. But if you think of it, the heart's on this side, your wires should be going on this side. So that'll help you kind of remember it. Anyways, V1 on that right side, 4th intercostal space. V2 directly across the other side of the sternum, same spot, just on the left side. You'll skip V3, go on to V4, and V4 will go right there in the 5th intercostal space now, and the mid-clavicular line. So basically, just go nipple line, or middle of the clavicle, straight down into V5. And once you down stick on, then come out back with your V3 wire, right in the middle of those two. It's pretty much very subjective, just good ballpark right there between V2 and V4, stick it there. Next one, V5. You'll actually have some people will skip V5 and go to V6, do the same thing here. Personally, I go on to V5, and it's going to be the same 5th intercostal space, just a little more to the left, in line with the where the torso starts coming into the underarm, right there in that anterior axillary line. The next one, V6, will be right in the middle of the underarm, in the middle of the armpit, and right there that same 5th intercostal space, and that'll be where you line that up at. Next one here we have, this is going back to the 3 lead here, but they each play a part in each other. This is referred to as your hex axial system, or your hex axial reference system, and it's just where each of your 3 lead views come from. If you look at this here, you're looking at your patient. When you look at your 12 lead readout, you'll see the first 3 on the left side will be leads 1, 2, and 3. Well, lead 1 is coming from 0, coming from the outside in that way. Lead 2 then circles around. Lead 2 coming this way, 3 here, and then your next one's AVR, coming back from the top right side of the patient going down. AVO, left side coming in, and then the AVF up from the bottom. And it's a good view, just look at it that way there. Actually, no, I'm sorry. I said it completely backwards. It's from the inside going out. Whenever you add those chest leads, that's what really helps give you the 3D view. So just look at this here. You've got the hex axial laid out in the background, and then your V1 through V6. If you look at them coming out from the inside, it's basically taking a snapshot, a 3D snapshot from the front around the chest there. So again, backing up, is all your leads are looking from the inside out, and or from this here, inside out, to AVF, V3, they're all looking really through the heart with its normal conduction. That's how when you back, it's like we just reviewed with the cardiac cycle, with your V2, which is your most common lead you'll see. And when you're looking at it through this way, the normal pathway of the heart, you can see the atrial beat first and the ventricles. That's how you get that normal rhythm you're used to seeing. Yeah, just a cool picture there gives you that 3D view of how the full kit fits together. Now on to actually, once you have your placements made of your wires, you will then go on to acquiring your 12 lead. This is where you will actually get to put your information in the monitor and then acquire it and be ready to then transmit it to the hospital or to your other medic crew coming. Whoever is the most important ones coming that can actually make that decision of where that patient needs to be gone to. The 2 things you'll need for acquiring this, you will need your patient's age and your patient's their real actual gender. If they are a transgender or cross-dresser or whatever, it would really help if you know exactly what they are, because that can make a difference in how they're actually made inside, despite how they want to be outside. And once you have everything else there put in, information put in the monitor does not take long at all. Then you'll hit acquire. Before you hit acquire, go and have your patient lay as still as possible for roughly 10 seconds, just a good time frame to tell them. It'll take that picture real quick. It will take 10 seconds to take the picture, and then once it does that, it'll take a second, think, and then print you out your reading. The whole process, put the wires on, information in, and get your printout, should take around 2 minutes. Or if you have two very confident people working it, you can have the whole thing printed off and ready to go in less than 2 minutes. I'm not worried about time for anyone else here right now. If you can get that reading and the EKG print before other help gets there, great job. That's what we're aiming for. So the STEMI thing you've heard about. What truly is a STEMI? And anyone got any guesses? No? Okay. So STEMI is an ST elevated myocardial infarction. And I forgot to talk about it here in just a minute. Let me back up for a second. The ST segment we're talking about there is this segment right here. I skipped way over it. But this here, whenever this part is elevated, that's when you're starting to worry about having the myocardial infarction or the heart attack. A heart attack and myocardial infarction are the same thing, different words for it. What rules in your heart attack and myocardial infarction is whenever this ST segment, it doesn't come back down to this baseline. It is then elevated more than a millimeter. If you pull up your North Carolina protocols, 1 millimeter is what you're looking for. 1 millimeter of elevation and at least 2 contiguous leads is what helps confirm your STEMI findings. So let's go back through it. Here we go, okay. Like I mentioned there, 1 millimeter of elevation or greater than 1 millimeter of elevation in 2 contiguous leads, that then helps confirm your STEMI. And if you have a LifePack monitor, for example, they will actually give you a printout at the end of your 12 lead and tell you how much elevation is in each of those ST segments. Pretty cool thing. I'm used to both the LifePack and the Zoll. That's one thing I really like about the LifePack better. But it's just whatever your service carries. I want to say there is actually a way to set it up on the Zoll. We don't have them where I work. So one good thing, you look at the people who study counterfeit money. They don't study counterfeit money, they study real money. So that way whenever they see something wrong, they know what's wrong. Same thing here, at y'all's level, I think make it easier. If you study and see enough normal looking 12 leads, when you see something that's different, you'll know something's up. Now, I showed on a couple slides back, there are a lot of things that can imposter STEMI or make a STEMI look like there's something there when there's really not. For example, you may see elevation in every single lead. That doesn't mean they're having, oh my goodness, every single thing in the heart's blocked. Every single artery is blocked, they're about to die on us. If you see all of them elevated, chances are they've got pericarditis, which is just inflammation there of the heart and the sac surrounding the heart, and then gives irritation system-wide. So again, here's your normal 12 lead. If you're looking back at your views, 1, 2, 3, ABR, ABF, or ABM, L, ABF, V1, V2, V3, V4, V5, V6, and then across the bottom, you have a continuous running of lead 2. Lead 2 has that normal. If we actually look across it, you got a P wave, QRS, and then your T wave at the end. And then a few seconds later, you got your next beat. And that's a very regular, normal sinus rhythm. EKG. You might notice the end here, just a little extra bonus, the extra T waves here on the precordial leads can be an indication that he might be a little dehydrated. But don't worry about that, no big deal. Now, look at this one here, get a bit different. This will be a heart attack. And this will be a big one, perfect. Yep, he's definitely got something going on. As you come across, you should read it from the left to the right. You can see, oh look, the ST segment is depressed on this side. Keep on going through. A little bit of elevation here, and look, bunch of elevation over here. You see that segment, as it goes through, never fully returns back up, or never fully returns down to that baseline. Something's up there. He's got some blockage going on, and something's really bothering his heart. And the one thing we use whenever we're confirming 12 lead is the depression on the opposite side leads. That can just help me know the determination or confirmation that yes, there's a STEMI going on. Whenever your 12 leads print out, they will also give you a reading at the top. For example, this one here says he has an acute MI suspected. He's got an abnormal EKG, and he is in an accelerated junctional rhythm. Basically meaning there's no P waves that you can see, or the P waves may be inverted. Something else is up with the P waves. And his atrium isn't contracting right, in other words. And through this as well, other things to notice, he has a septal infarct. Well, if you go back there and read it, and like we talked about the ICL leads, the septal leads are where your elevation is at. That is where you say, oh look, there's that, there's my heart attacks occurring at. Cool, hey, paramedic crew, doctor, here's what we see, we have elevation of these leads. We'll see you guys when you get here. Just gives them an extra heads up, so they know what they're getting into. I should come down here, I mentioned earlier, we'll talk about the protocols here. This is your North Carolina protocol. This is just the generic North Carolina chest pain protocol. Talking about who can give who can place that 12 lead. If you look over here, either with chest pain starting off here, yes, they have chest pain. But guess what? A basic, they're in the white box, can give or can start at 12 lead. 12 lead EKG, ECG, EKG, same thing. The reason why the P is on cardiac monitor, basically it's just saying that the basic cannot confirm and they can't monitor that rhythm for a running period of time. The paramedic has to be the one to do that because they've had the extra 6 months of training just on cardiac issues and what's going on there. Follow your algorithm down some more. Acute MI STEMI, maybe you'll hard to see. STEMI is equal to greater than 1 millimeter of ST segment elevation and 2 contiguous leads. Yes, if they have that, not back over here yet, we're going to the STEMI plan protocol and going through what is going on and following the rest of the protocol all the way through. And from that, even if they have that there, now we're going to be given our aspirin, which they can chew up, and intermediate level, you're going to go ahead and start an IV, basics, don't worry about the IV. You can go on down to nitro. That is what the what your indication is next, your next medication to give. Of course, you want to give that only if their blood pressure is greater than 100 and they've not had any of the ED drugs within the past 24 to 48 hours. Nitro pace is a wonderful thing, however, it's not basic level. And of course, as you mentioned through everything else there, follow the full protocol all the way through. Medications for chest pain, aspirin. The purpose of aspirin is to prevent further clotting. Basically, all it does is make the blood a little bit slicker so that the platelets can slide past the blockage a little easier and not stick to it, make the clot get any bigger. Nitro works to dilate the vessels and also reduces preload. Preload is basically the pressure coming into the heart. And in the cases of that right-sided inferior heart attack, this can be very detrimental in that it will drop the blood pressure to the point of it kills the patient. Not every time, however, it can be very likely to happen sometimes. This is the reason why I would say that nitro should not be given in an inferior STEMI. I know you can't read a EKG at the basic level, but if you want to be an extra achiever and say, oh look, I believe this patient's having an inferior STEMI. I think I want to hold off on this nitro until the paramedic crew gets here and looks at this a little deeper. I'd say go for it. I wouldn't have a single problem with that. If they get there and say your paramedic crew's only 5 minutes out, 5 minutes giving that nitro is not going to make that big a difference at that point. Especially if you're suspecting that inferior STEMI. A little further here, this is why you give no nitro in that inferior STEMI we're talking about. Whenever you do that, you basically the blood has no way to pump through the heart anymore, and so thus there's no back pressure pushing it through. This here is just a classic picture of your inferior STEMI. Back here on those inferior leads we're talking about, you have your elevation. Good bit of elevation there, bunch. There's 6 millimeters of elevation. These here, and then also in your ABR, all of those inferior leads, and even a little bit more involvement in other places as well. And then you can confirm it having your depression in one in ABL here. Just helps to confirm you got your STEMI going on, and I'd like to hold off this nitro and see what the paramedic crew says. So as we start coming together here, we'll get ready to do a little bit of practical work here and actually put on a 12 lead. Anytime you suspect a cardiac event, go ahead and run a 12 lead. You're not going to be dogged at all, any reason at all. I think he had something going on with his heart. I went ahead and ran a 12 lead so that way the paramedic crew can look at it. And that way we have one initially right when we get on scene. If he doesn't need it, hey, no big deal. Stickers don't cost that much that you can't use a little bit of money on this patient here. However, if he is having something going on, hey, great. We are able to catch it a little bit earlier. Don't delay your care in critical patients, another point. If that patient is truly going on, there's the saying in EMS, treat your patient, not the monitor. Like I mentioned earlier, there's going to be a lot of imposters that look like a STEMI, but are not. If you get caught up too much on trying to figure out, is this a STEMI, is it not? You can sit there and watch your patient crashing behind you, and here you are focusing on this piece of paper, and you're not even sure what it means. And so work on, of course, treat your patient, not the monitor. Get it great. Make sure you work on supporting that ABC all the way through, and do it great. The key to a great paramedic is a great basic. And if you doubt it, don't be afraid to ask for help and ask the crews that are responding to you. Especially, you can call on the radio, call on the phone if you got them, and just say, hey, here's what we've got. I'm not sure about this treatment. Where I live at, I'm about 30 minutes from the closest ALS unit. So with that, there's been times before, even me as being, now being a paramedic on scene, but in my days before, being a basic on scene, just saying, hey, here's what I've got. What else can we do for them before y'all get here? Here's what I'm seeing on this, that, and the other. What's going on? I know y'all are still 20 minutes out. What else can I do? And from that as well, I've also flown a patient before, EMS even out to the scene. Just based off of, hey, I think something's going on. Go ahead and get mom in the air. And the time I did that, I was actually due to road conditions. The EMS unit couldn't get faster than 20 miles an hour through some icy roads, but the sky was clear and the helicopter could fly. So we had the patient loaded into the helicopter as the EMS was pulling up. Great day, confirmed stroke, and the patient still ended up surviving it. Essential to follow up on your skills and make sure, like I just mentioned, follow through on everything. Make sure you don't leave any part of it out. Don't be afraid to pull out that protocol book. If you're questioning something, pull it out. Okay, what else can I do next? I'm not quite sure. Let me get it here. And if you're still the only one on the scene, ask if there's anyone else around you, any non-EMTs. Hey, is there anything else you see that I've done that maybe I should be doing, or something else I've missed, medications or something else? Let me know. If you've got other basics there or other EMTs, great. Use them. Put your minds together. Think about it. Work through that scenario together. Bounce ideas off each other. It doesn't take long at all to say, hey, okay, here's what I'm thinking. Here's what you're thinking. Let's put it together. Two minds are better than one. And with that, any questions else on this? Any questions, comments, major healthcare problems? Nope. All right, so next thing we're going to do here real quick, we're going to get together, and I have a mannequin here, and we are going to apply a 12 lead to our mannequin here. This will be a group exercise. So, let's set this up here. So we're going to, first off, like I mentioned earlier, the first thing you do with your patient, the first wires you put on, once you're saying you're going to run a EKG, is going to be your limb leads. Whenever you pull these out of the bag, they will be, or out of your monitor bag, however it's set up, they will more than likely be tangled up. So you'll pull them out. I try to run my fingers up and try to split my wires up some. That way I've got them, I know, okay, these wires are going to go here. Got my arm wires in my hand, leg wires in my other hand. That way I can work through it a little bit easier. Keep things a little bit neater here on the patient as I throw them around some more. And I'm not actually going to stick wires to this patient here, or to this mannequin, just because it'll get them all gooey. Not like he's not already. But on the one thing I like about the 3M leads and the way they come packaged on theirs, they actually have a little, it's basically like a piece of sandpaper on the back of the paper that allows you to pull that off. And actually pull it off, you can take it and use that to kind of sand down the skin, if you will, and prep it for the prep it before you put the lead on. That way you pull it off and it's likely to stick a little bit better. So pull off your leg leads. Your your right leg lead is going to be like a grounding or like a neutral lead. And so as you put it on, you won't really get a view from it. It'll just be more of like I said, that grounding wire that goes down. Just stick them on right where you go. Pull your upper limb leads out. You're going to stick them on as well. After you got that, this can be the point as well where you've got your partner, whoever's working with you, go ahead and get your wires ready for your other 6 wires for your 12 lead, having them out, getting them ready to go. And so you can be ready just to snap it on once you get going. And a lot of places you'll see that will actually leave the stickers attached to their wires. That can be great if you're running a 12 lead every couple hours. However, these stickers will dry out. And as these stickers dry out, they can, as they dry out, they won't be as effective in picking up. First of all, it's just sticking to the patient. And secondly, the gel itself will dry out, and you won't be able to get a good reading on your patient. And you'll have a lot of static, or you'll also either, in some cases, even not even pick up the electrical conduction that gives you your reading. The next section here, same thing with your other wires, your precordial wires. As you pull them out, sort them out in your fingers. That way you get it somewhat neat. As one of you, if you're your partner or someone else is sticking these wires on the patient, go and have whoever else is with you putting your patient's information in the monitor. That way you can be, again, cutting out time, being ready to go. Once you pull them out, again, you'll find where you're going on your patient. Pull out. As you find it on your patient, look for that 4th intercostal space. V1, go right down that right side sternum. V2, right there on the left side. And then you'll find V4. And you'll go to the 5th spot, right there in the nipple line, mid-clavicular line. You'll stick it there. V3 will go right in between it and V2. V5 and V6 will then go around the outside. V6, you can kind of right in line again. Make sure you palpate the right spot. And then V6 will go right beside V5, right there in kind of the middle of the underarm. Once you've got that all applied, you will then take and plug it up. Your box should be somewhere where you plug it in. Should be somewhere along the set of your 3 lead wires. And you just plug it in. Once you plug that in, your monitor should automatically switch. And since I don't have a controller for this monitor, we can't actually simulate it. But you will then pull up your monitor. This here we're using the LifePak 15. That's what our local service here uses. You will then go to your 12 lead. The first thing you'll do is it will ask you for your patient's age. Very simply put in your age. Say, for example, I'm treating a 67-year-old female. 67. Select female. As I do that, it will automatically switch to acquiring the 12 lead. Since this is not a real patient, I can't get an accurate 12 lead just because it has nothing to read. But again, like that, very simple. It will then print you off a reading. Once it prints off your reading, then you can go to, like we had in the slide earlier, figuring out what is, going through reading it, looking through, do I see anything out of the norm? What does my little box at the top say? Box at the top or your results actually have it written at the end. After all your 12 leads printed off, they'll be to the very end of it. Those boxes there where it gives you the readout, what it thinks is going on. The monitor has its own system for computing. Okay, I think the patient has this, this, and this wrong with it, based on their age and based on their gender. A lot of times they'll just say abnormal findings for example, 40-plus-year-old male, and it'll say something's wrong, but I don't know what's wrong. That box where it tells you what's going on, a lot of times be quite inaccurate. It's great just to look at and get an idea of what's going on. However, you can't really use that box to confirm that this patient's having a heart attack. Certain agencies actually require you, believe it or not, to use that box to call a heart attack. I want to say there's one agency down near Charlotte that does that. That unless that little box says that this patient is having a STEMI event, you cannot call the STEMI, call the cath lab, you're going to let them know what's coming in. The nice thing about these monitors too, all your modern monitors have a way to transmit. So say for example, you're just a basic service and your ALS crew is a ways out. You can say, okay, I don't know what's going on here. Go ahead and get on the phone with your, or first go ahead and transmit this. You can take it, transmit it through Bluetooth to like a MiFi modem if you got one of those in your truck, or a cell phone, whatever else. Some way, there's a number of different ways to transmit this to the hospital. And then your hospital can be, your ER doctor can pull it out, look at it and say, okay, this is going on. You get on the phone with them and saying, hey, hey doc, I've got this patient, I just sent you the 12 lead. What's going on with them? Do I need to, what else do I need to do? Do I need to go ahead and fly them to you? What else needs to happen here? And so that way it's not you interpreting it, since the only people here in North Carolina that can actually interpret the 12 lead is a paramedic in the pre-hospital setting. And then in the hospital, I'm sure a doctor, and they have full, they've got a full list of who in the hospital can actually interpret the 12 lead. But in the pre-hospital setting, the only people that can legally interpret it is the paramedic. EMT basic, intermediate can both acquire it. Place leads acquire the 12 lead, but they cannot legally interpret it. Just want to make sure that that key, so you don't put in your narrative, patient's having this, this, and this per me. Patient's having this per the paramedic, I'm sure it would be okay. But you can go off what your agency says. If your agency says, yeah, I can do this, no, I can't, then that's what you got to do. Some studies are actually showing there's certain places out west that have basic level services, to where their basic level services out in, whether it be Wyoming, Montana, some of those old west states, the basics are actually doing a lot of the interpreting and a lot more care than we are here, just because they don't have paramedics available to them. Here we have the luxury of having paramedics available that can say, okay, yeah, this is what's going on, and really pre-hospital doctors in a lot of ways, and because they have so much extra training and knowledge about what else is going on with the body systems. So, any other questions with that? If we don't have any other questions, I believe we're good to go. Thank you all for coming today. I appreciate your time. Hopefully I didn't bore you too much. If you've got any questions, let me know. I can send you my email, give you my PowerPoint, whatever else information you want. And so don't leave just quite yet. We do have a quick test for you. Just 25 questions or 24 multiple choice questions, and then like an essay style question. Don't worry, don't sweat it too much. Just all do fine. I've got confidence in you. So thank you again. We'll pass this test out and get everything taken care of.